specific context of COVID-19. So the session will be taken by Dr. SEEMA RAO. Dr. SEEMA is a psychiatrist that has been working in palliative care for a long time, and presently she is working in KMC Manipal as palliative care physician. So welcome, Dr. SEEMA, and it's over to you.
Thank you, Sunil. And good afternoon, everybody. Can you share the slide sharing? Can you start? The first slide. We are in the last. Yeah. So thank you so much for inviting me for this lecture. And I must say this wouldn't have been possible without Dr. Chitra and Sunita. I have borrowed most of their slides. So let me go ahead with the presentation. As we know, next slide, please. Yeah. So this brings about the COVID-19 situation brings about a lot of anxiety in all our minds. Okay. And not only of the patient, but generally with everybody. Like if you see, there is a lot of anxiety, that is worry about our personal safety. The physical distancing measures have made life more difficult. We are worried about carrying, as doctors, when we go to work, we are worried about carrying the infection back home. And as patients are also scared of catching infections when they come to the hospitals. Even going to a grocery store to buy something is creates a lot of anxiety. So there is also a lot of uncertainty around when is this going to end? How long are we going to go like this? There is a lot of financial losses happening. Our normalcy is totally disrupted. This leads to uncertainty. Uncertainty gives birth to fear and anxiety. So there is a next slide, please. What we as mental health professionals know that it has an alarming implications today's situation for the individual and collective health of the individual. There is emotional suffering, there is social suffering, financial suffering, as well as spiritual, in addition to the physical suffering that the patients undergo. So in addition to the pandemic that is occurring, there is the short term as well as long term psychological effects are going to last. That could be the second pandemic that is coming after this has resolved. Next slide. So as we see, like what we are experiencing and seeing today is a sense of loss of normalcy. Hello, the slide is gone.
Just a minute.
Yeah. What we are experiencing collectively is right now, both individually and in the community, is a sense of loss. Anything that the sense of loss is likely to add on to grief, feelings of grief and blaming. We are separated from the families. Especially, there are certain vulnerable individuals who are the homeless, the migrant workers, and the day-to-day laborers who are grappling with poverty. Okay, and in palliative care, especially when palliative care is a field that is high on touch and low on tech. Today, our interactions with our patients are impeded because we have to rely more on technology and less on our the communication way we communicate has changed tremendously. So all this are compounding the stress in both the patients as well as in the providers. Next slide. Okay, the studies have shown in terms of what has been done in China as well as what has been done in Italy, where the pandemic started and where the maximum effects of it was felt. The various studies have shown that there is increased distress. Almost 53.8% of respondents had moderate to severe psychological distress. Either it is anxiety or depression or increased level of stress. Next slide, please. Which indicates that we have to focus, in addition to saving lives and treating this disease, we also have to focus on the effects of the disease that is there in the patient, as well as in the healthcare providers, and also in the caregivers of the patients also. And who are more vulnerable for this are the elderly and people with comorbid diseases. If you have seen the news or if you watch it, everybody knows having comorbidity increases the risk of complications and even death. So these vulnerable individuals are more at risk. The elderly are more, women and children who are not able to understand what is happening around them, whose normal life is disrupted. These are the individuals who are likely to have more morbidity. So we need to integrate psychological interventions everywhere, right? It should reach the patients, it should reach the community, even people in the community who are not sick. And it should also reach our palliative care population as well as the healthcare workers also who are at increased risk. So the integration of psychosocial interventions is extremely important at all levels. Next. As I said, when we talk about patients, uh, uh, which subgroup or subset of patients are more at risk are people who have been asked to quarantine or isolate themselves at home, people who contract the disease. Obviously, there is a lot of looking at the fear and anxiety that is there, they are likely to undergo more distress. Again, vulnerable population and those with comorbidities, and people who have lost their loved ones to this disease, they are also at an increased risk. And health workers, actually, if you see, there are reports about people becoming aggressive in their when they are quarantined. Lately I saw one video of one woman running around in the hospital threatening to infect others. um, and people were most likely this was an aggravation of a coexisting or a previously existing mental illness in that individual. Being confined to one space is likely to trigger off any past psychological illness or morbidity. So we have to be very careful when we isolate people and ask them to quarantine themselves. It is important that we assess for risk of psychological morbidity and offer them more support. Next slide, please. So as I said, what are likely to happen? What are the psychological issues that are likely to come up? Okay, primarily it is the emotional distress. As I mentioned earlier, certain unhealthy behaviors are likely to get aggravated. By unhealthy behaviors, it could be violence, it could be aggression, it could be even increased substance abuse. See, people who are anxious will try to alleviate or reduce that anxiety by various aspects. So some of them use healthy coping techniques, some might use unhealthy. And these unhealthy behaviors are likely to aggravate in isolation or when they are confined. And the stigma of the disease itself can give rise to very unhealthy behaviors. Let us look at each one of it separately in the next slides. I will be talking about each one of it separately. Next slide, please. So what are the common manifestations of psychological distress that we see? So essentially, it could be physical, it could be cognitive, it could be emotional. You can click everything. One, two, one more click. One more. Yeah, one more. Yeah. So the behavior could be physical distress. It could manifest as physical distress with increased heart rate, increased sweating, restlessness, agitation, stomach upset, multiple aches and pains. Or it could be emotional, where the person feels extremely stressed, irritable, angry, anxious, constant obsessive ruminations about sanitizing yourself, cleaning yourself. Then there might be low mood, sadness, difficulty concentrating in day-to-day activities. Person is unable to relax. It can also manifest behaviorally as fatigue, changes in eating patterns and sleeping patterns, sometimes even aggression, vague, uncomfortable anxiety or sensations. In some people already who have had a mental illness or who have had depression or phobia or panic attacks in the past, it could lead to worsening of the, it could lead to relapses, and sometimes on worsening of ongoing health problems. In elderly people with comorbidities having chronic health problems, it can worsen. And as I said, increased use of substance abuse can happen. So these are, some of these are normal reactions. When each of us go through anxiety or stress, we might experience this. But sometimes this might need more intense interventions. As we say, whom should we refer for support? Those red flag signs, as we say, are when people have some sort of suicidal ideations, when the agitation and confusion are very severe, there is disorientation, the substance abuse to problems, there is hallucinations, delusions. In the presence of all of this, then uh, we will have to refer them to more specialized mental health support. Next slide. Yeah. So as I said, why the substance, we've already discussed this about substance abuse. Um, Also important to note that not only is it alcohol, but patients also have a tendency to self-medicate with whatever medications that they have. The unhealthy behavior would even include them stockpiling these medications. Especially in palliative care, patients on opioids, they have a tendency to stockpile it. Um, they might get very distressed when they feel that they may not be able to access the support to get this medication. So we have to be very careful with the type of prescriptions that we are giving, how they are using the drug. Also, benzodiazepines are another group of drugs that people tend to use it more. So self-medicate themselves with. We have to watch out for all this in our patients. Next slide. Domestic violence is another problem that we encounter when in couples or partners where there is already issues are there, being confined to a space with the partner uh, can lead to increased domestic violence. The loss of income, the loss of roles within the family when both are present at the same time, along with the anxiety and the uncertainty the disease has brought, can aggravate the mental health problems and cause increase in domestic violence in the family. Here it is not only the partners that are affected, but the children who are also at home with the schools being closed down are subject to, are also at increased risk. So on one hand you have a patient, and one hand, the other hand, the families who also have increased risk of psychological morbidities. Next slide, please. Again, sleep issues are very common. Next slide. Also, there is accompanying all this is a spiritual distress with patients who have contracted the disease and with the family members about why did this happen to them. Okay, spirituality is that dimension that helps us find meaning and purpose in life and helps us to remain connected with ourselves, with our surroundings, with people around us, and with God. An illness disrupts this connectedness and our sense of meaning in life. And this can give rise to a lot of distress. Next slide. So as you can see, psychosocial issues does not only mean um, depression and anxiety. There is a wide variety of issues along with it. There is spiritual distress, there is psychological distress, along with the physical distress that comes in. One of a unique aspect of this COVID experience is the presence of stigma. Stigma means that people are being labeled or stereotyped and discriminated against, and they experience a loss of their status, or they feel that they're treated in a different manner. This stigma can give rise to a lot of maladaptive behaviors. Patients may not report their travel history. They may not come to the healthcare provider if they have fever. They may run away from the quarantine. They may not quarantine, self-isolate themselves even in the presence of disease. and sometimes they may hide their COVID positive status and move around even to the doctors. This can lead to increased spread of infection also, and they may not comply with, and it will impact the control of the disease also. Okay, so it is important that we do not stigmatize the patients with COVID. Now, next slide. How do we ensure that we do not stigmatize? As you have heard before, we had the American president calling it the Chinese virus, the Wuhan virus, right? So that means stigmatizing it to either a location, to a ethnicity. We have seen a lot of attacks on Asian people of Asian descent abroad, accusing them of bringing the virus to the different countries. In our own country, we have seen discrimination based on religion. Okay, so these sort of stigmatization we should not attach to this. And one of the reasons why the name COVID-19 has come about is to take away the stigma of the Wuhan virus or the Chinese virus. It is the coronavirus disease 2019. That is how COVID-19 has come in. Also, calling people as COVID warriors or COVID cases, COVID victims, or COVID suspects is how, again, the words that we use can create a lot of stigma. It could be better if we say a person suffering from COVID-19 or individual affected with the COVID disease rather than labeling them as cases, victims, suspects, or even warriors. A positive connotation, but this is also a stigma. And using words like transmitting the disease, infecting another person, spreading the disease indicates that a person is doing intentionally. It has a very negative connotation to it. So using words like this, better would be he acquired the disease or he contracted the disease. He didn't transmit it or infect it or spread the disease. So terminologies matter a lot. And most importantly, when we address the stigma, even healthcare workers are also at the receiving end of this stigma, isn't it? We have also important, we have to keep away from the rumors and misinformation that comes out from this. So addressing stigma is extremely important. Next slide, please. Grief and bereavement at the time of in COVID-19 also is very complex. By grief, we mean our experience of the loss. We grieve when we lose something. Okay. In COVID-19, it is the grief, the loss is multiple. It is loss of normalcy, loss of control over our day-to-day life. There is loss of control over our day-to-day lives. There is our physical connections with what we do, our job, even going to the grocery store, everything is lost. There is financial loss. Sometimes when we contract the disease, the health is lost. And this is compounded by the isolation. People who get COVID are isolated from their family. They and the um, caregivers are isolated from giving care to the patient. So the isolation compounds the loss. And even after death, the process of funeral and burying is also impacted. So the loss is very complex here. There is a whole community that is grieving. It is not only about individual loss, it is a community loss. Organizations have professionals, individuals are all grieving the loss of normalcy. So this sort of makes the situation quite complex. Next slide. So there are various types of grief that are very specific in this particular situation. Anticipatory grief is the grief when we are expecting a loss. Like when we were hearing stories about what was happening in Wuhan or what was happening in Italy. We here in India, when our infection rates were not high, we were waiting in fear, worry, awaiting the spread of the disease in our country also. That fear that we were experiencing is anticipatory grief. Even vulnerable individuals also experience increased grief at this point in time because they hear over and over again that people who are above the age of 60 with multiple comorbidities, who are immunocompromised, are at more of risk of mortality. So they also undergo a process about what will happen to them in case they catch COVID, that is increases the grief. The likelihood of grief becoming complicated, that is prolonged and lasting and becoming more severe is more when patients die with COVID, because also when patients do not die in deaths occurring both due to COVID and non-COVID, because in the current situations, the funeral is impacted. The way people are normally there is a mourning process that occurs where families come together to grieve, which is not possible when death occurs in today in the context. Even for people with COVID, it is even more severe. Even non-COVID deaths also, we are not able to hold that family grieving does not happen. So this can increase the risk of complicated grief. The add to it the financial hardships, the disconnect that is happening, chances of complicated grief is much more. And this um, delay, delayed grief or disenfranchised grief is also more common because the normal process of mourning is not occurring. So the the relatives of one people who have lost their loved ones are likely to be isolated or quarantined and are not able to express their grief adequately. So this is called as disenfranchised franchised grief. So we have a likelihood of more psychological morbidity with all this occurring. Next slide. So how do we cope? Okay. So generally, all of us, most of us are healthy. We have normal fluctuation in our mood, normal sleep patterns. We are physically well, full of energy, and we are socially active and performing very well. Now, this situation has come in. This pandemic has resulted, has shaken our reality or our normalcy. All of us are going through some sort of loss. We are reacting, we are in the reacting phase. We are nervous, we are sad sometimes looking at all the news that is happening. We are irritable sometimes. There is trouble sleeping. Most of us may experience some tiredness, low energy levels, tensions in our body, headaches. Sometimes we might delay or postpone things that we are doing. We are worried about our loved ones, the safety of our loved ones. Our social activities are drastically reduced because of the stay-at-home orders. So all this are normal, say, normal in this situation, and we are all reacting to an unaccustomed loss. Okay, so most of us will find our own balance and learn to cope with it. Almost 80% of us will find and we learn to cope with it. But for some of us, this we may not be able to cope adequately. We may have increased anxiety. It can come out as anger at the government, anger at the healthcare professionals for not taking care of us adequately. There might be increased sadness, hopelessness. Sleep may be extremely disturbed. There is increasing fatigue. There are more aches and pains. Decreased performance and social avoidance or withdrawal can set in. That is when we are we need a little bit, or individuals in this space will need a little more help, our psychological help. If they are not still not able to cope with that situation, they might go into the ill phase where there is increased psychological symptoms can set in, where they are more prone for anxiety disorders, depression, or other psychological morbidity. And at that time, contact with a mental health care provider is a must at that point in time. Now, how we go from one phase to another depends a lot upon our personality, our past experiences, that is what have we learned, and also depends upon our environment. Next slide, please. So how can we assess distress? In palliative care, we use what is called as the distress thermometer, which is a screening tool that helps us to measure the distress. It is visual analog scale, and is there, where 0 means no distress and 10 means extreme distress. We can look at, ask the patient to circle the number where they feel their distress is. Anything above 4 will require specialized interventions. Next slide, please. Yeah, distress more than 4, these individuals need more support. If possible, a mental health care provider can give support. When the distress is mild, then only psychological interventions are necessary. If it is moderate to severe distress, that is anything above 7, 8, 9, or 10, then we may have to look at both pharmacological as well as psychological intervention. Next slide, please. Yeah. So one of the primary things that we do at this point in terms of psychological intervention is education. There are two psychoeducation. There are three aspects which anybody can do. Actually, any healthcare provider can help in psychoeducation. There are three interventions here. One is therapeutic interaction, two, clarification of the information that we need to give, and enhancing coping in the patient. So by therapeutic interaction, we mean establishing a good rapport with the patient and the caregivers, so that there is enough trust so that we are able to share the information that we need to give to the patient. Next slide. When we come to clarification, there are certain steps when we want to provide any information. One is understanding how much the patient knows about the illness. So this we can start off with asking a open-ended question to the patient, asking them what do they know. Once we have an idea of what the patient already knows, then we just have to fill in the gaps and correct any misinformation or deficiencies that is there in their knowledge. So when we do that, what we need to keep in mind is that when we provide any information to the patient, any diagnosis, it should be in a language that the patient and the family understand. That is, it has to be, we have to remove the medical terminologies and explain, not use too many medical jargons, and explain it in a very simple manner. Short sentences, be very specific about what you want to explain, and ideally you have to not more than 3 facts at a time. After you have given the information, you have to check what the patient understands by asking him, now that I have explained everything, what have you understood? Can you explain what you have understood? This is very important because it helps you understand if they have misinterpreted something that you have told. It is also important during this time to respond to patients' feelings about what you have said. Being empathetic and showing concern is important at this time. Next slide. The third aspect is by when I said that you have to be empathetic, it involves. Hello, can you hear me?
Yes, ma'am.
Is it clear?
Yes, ma'am. It's clear.
Okay. So when we talk about enhancing coping, it is about allowing the patient to um, express their feelings. Okay, and it's not only about expressing their feelings, but as a healthcare provider or as a person when we are counseling, it is important to validate those, acknowledge and validate the feelings with statements of support. Once they have expressed whatever is their feelings are, then we focus on solving the problem. What is the current problem and how do we go about solving it? Here it is important to focus on what we can do rather than what are the deficits. It is important to look at how we can help rather than the difficulties that is there. One of the important aspect is crisis counseling. Here, allowing the patients to look at the moment, what is there at that point in time, and small realistic goals for every day, and seeing how we can manage that. Other aspect here is bringing in experiences of other patients who have gone through the similar process, who can share their and sharing their stories to reassure the patients coming to you, and also strengthening the support systems the patient has. It could be, if physical presence is not possible, they can access support, these supports through phone, WhatsApp, or through conferencing or FaceTiming, what we can do in this particular circumstance. Next slide. One of the major challenges in communication in the context of COVID is the rapidity with which things occur. A patient coming to you with the diagnosis of COVID-19, you are not familiar. You're meeting the patient for the first time, and you have a full PPE on. Communication through the mask is very difficult. uh, all non-verbal means of communication is lost because the facial expressions, the eye contact is not there. Um, so it becomes very difficult to communicate. So at this point, what can we do? Now, and touch is also, you have to keep your contact with the patient who has tested positive to the minimum. So how are you going to deal with this issue? One thing is, in substituting verbal communication to the non-verbals. Like, I'm sorry, you cannot see my face behind the mask. Actually, I'm smiling at, I hope you realize that I'm smiling, giving you a smile, or using the tone in your voice to indicate, modulating the tone appropriately so that the patient feels reassured. Using calling out, introducing yourself by name and addressing the patient by their name will also help in restoring a level of comfort. When you talk on the phone or through a FaceTime or a video camera, it is extremely important that we follow certain etiquette in teleconferencing. Generally, what we do is we tend to be looking at the screen when we are speaking. So, for a patient who is sitting on the other end, it looks as though we are not looking at them. It is important to look at the camera when you speak. So this gives an indication of an eye contact. Also, when we are writing something on the phone, when if the patient is watching you through through the screen, it looks as though we are fidgeting or looking away. So it is important to tell the patient that I'm writing down something, but I'm also listening to you. So these are certain training or etiquette that we need to learn when we have to communicate through the social media. Also, another aspect is when a patient with COVID suddenly becomes serious or needs much more help, communicating with the family also becomes little difficult because there are heightened emotions at that point in time. There may be anger. As we said, grief is complicated here. So there are chances that there will be guilt, there will be blame, there will be anger. Some of this anger may be directed at the healthcare professionals also. So we have to learn how to respond to this. As palliative care physicians, we are taught to we are trained in dealing with complex communication situations. So one of the techniques that what we use is called as the nurse technique. Next slide, please. Yeah, so this is a nurse protocol that we use for dealing with for empathetic communication in very complex situations. One is, if a patient is very upset or angry, you have to name or mirror the emotion, like saying them, you seem to be very angry, why don't you sit down and we can talk about it. If okay. And second is, you have to tell them or express to them that you understand that the emotions that they are going through. I can imagine how stressful this situation for you. Anybody, you are normalizing that, the anger or the stress that they feel. Anybody in your situation would be angry at this point in time. So this is understanding. Respecting the R stands for respecting the patient or caregiver's emotions. You can express this by saying that I respect your feelings. I know that this situation can be very troublesome, but quarantining yourself or isolating yourself is very important at this point in time, and this acknowledging and respecting is extremely important. And the fourth point, the S in the nurse protocol, is about offering words of support. Okay. Is there someone else that you would like to talk about this who can support you through this situation? Or let me see how I can make this easier for you. So offering your support and exploring, the last E stands for exploring the emotions further. Tell me more about your concerns. What can I do for you? Okay, so using this nurse protocol when patients are angry or extremely anxious, will help you to reduce their anger and also uh, convey empathy to the patients. Next slide, please. So this is an algorithm, I think, which is there in the ebook, which guides you through how the gamut of psychosocial interventions at the time of COVID. This is a single one-page algorithm which is there in the ebook, and it gives you an idea of what to do, how to go about assessing the psychosocial distress, and also the do's and don'ts of that. So I think this ebook will be available, I think, isn't it, for all of you? So you can go through it in detail at that point in time. Next. So coming now to the healthcare providers, many healthcare providers are encountering a situations where they are also grieving a relative or grieving a loss, and there is a lot of moral distress, extended work hours that happens, and all they are also undergoing through a lot of stress. Next slide. So in this situation, during generally the burnout among physicians ranges from 38.7 among palliative care physicians to 54.4 um, um, in internal medicine and other specialties. Okay. In the, during the time of COVID or any pandemic, last time it was a SARS pandemic, lot of studies were done to assess distress in the physicians. Non-specific psychosocial distress was seen in almost 71% of the healthcare providers, and increased anxiety and depression and also post-traumatic stress was found. Next slide, please, which indicates that even the healthcare workers, it is not only patients, but also the healthcare workers who are under more stress. One interesting fact was the frontline workers who were actively treating the COVID patients indicated much lesser burnout and stress levels than the people who were in the wards. Next slide, please. So when there are three things that we need to look at among the healthcare providers: burnout, compassion fatigue, and moral distress. Burnout is that stress that arises from the clinician's interaction with the work environment. And compassion fatigue is that arises from his work with the patient, relationship between the clinician and the patient. And moral distress occurs when we have to carry out acts that run contrary to our beliefs. Next slide, please. So in COVID, the workloads, work schedules are disturbed, extended shifts are there, sleep patterns is disturbed, there is increased exposure to morbidity and mortality, and the decision making, treatment keeps changing on a day-to-day basis. There is a lot of information overload. There is sometimes there may be an inability to provide care, okay, because deliver care despite taking oath because of the resource constraints that we have. Moreover, there is the risk of taking back the disease to the family. People have to, even healthcare workers have to quarantine themselves after working in the COVID wards. So that causes separation from family and social support. All this can complicate matters in case of the pandemic. Next slide, please. So again, we healthcare providers are an increased risk of anticipatory and complicated grief. Next slide. Okay, so I think I'll skip the clinical features. Next slide. Next slide. Yeah. So how do we manage this? We have to have a three-pronged approach to manage the burnout among the healthcare providers. One is at an organizational level. It's important to have adequate allocation of resources, adequate PPE, safety of the individual is extremely important. Debriefing after coming out of those managing patients is important. Having a manageable work schedule, training on how to upskilling yourself is extremely important, and recognition and reward for working in such highly stressful situation is also extremely important, and that is how organizations can work to mitigate burnout. On a professional level, it is important to upskill ourselves on effective communication, learn the latest evidence-based decision makings, that is algorithms that are coming out, and keep ourselves up to date about how to manage. Having competency reduces stress levels. Also, having a cohesive team, a mentor to whom we can talk to, and can reduce the stress levels. On a personal care, it is important that we take care of ourselves also in this situation. Now, how can we take care of ourselves and maintain a good work-life balance in this situation? Next slide. There are 5 ways which are evidence-based ways that we can go about doing it. One is what is called as promoting safety. It is important for us as well as the community to feel safe. At this point, what we need to do is keep learn to use stringent infection control methods both in the workplace as well as at home. That is one way of keeping ourselves safe. And if intrusive thoughts keep coming in, it is important to tell that out of 80% of the people with this disease do not have symptoms or have mild symptoms. So it is important to keep reminding of the fact rather than just focusing upon the ventilators, the mortality that is likely to occur. Second, it is important to promote calming within ourselves. Okay, the calming involves using mindfulness, meditation, yoga, breathing exercises, or doing hobbies that give us um, joy, or exercising. Whatever it is that helps you calm yourself, you need to look at techniques to calm yourself down. Third is remaining connected. Remaining connected with work in some way through the internet or through other activities, remaining connected with the loved ones. It is physical distancing, not social distancing. You could remain connected with people through the social medias. Um, Also remain connected with our hobbies, and also with God in a way. If you believe in God or in spirituality, being connected is also extremely important. Self-efficacy, having control is very important. Right now, we are in a situation where most of the controls are taken away. But inside our homes, having a routine, controllable routine, doing things, having a structure in the way we live in the house, waking up at a specific time, cooking at a specific time, and maintaining that structure gives us a sense of self-efficacy. That is extremely important. And maintaining hope, looking at what is positives, having a gratitude of what once you have, finding meaning and purpose in the suffering that you are experiencing currently, are these 5 ways of self-care that we can look at. Next slide, please. To summarize, what we can understand from this is there is an increased risk of psychosocial distress both among the patients, their caregivers, as well as the healthcare providers during the pandemic. It is important that in addition to looking at treating and saving lives, it is important that we focus on the psychosocial aspects also. There are 3 A's of this. One is awareness, be aware of this risk. 2, acknowledge and recognize the distress when you see it. And 3, act upon it. Because by acting upon it at the earliest, it's the surefire way to reduce the psychosocial morbidity, both short term and long term, that is likely to come out of it. And I think in the ebook that is there in the PalliCovid ebook, it gives you a simple way of how you can address the psychosocial distress, whether it is in the burnout, whether it is the grief or the distress that comes in. There is a very clear-cut algorithms given which you can follow. Thank you.
Thank you, Seema. The session is open for discussion. If anybody has any comments or questions, please come up. Anybody? Yes, Chitra madam.
Seema, that was very good and so much in detail. Thanks for the uh, good presentation. I would encourage people to discuss or share their experiences so that this becomes, this is more about the emotional issues that we face, and we expect that the healthcare workers would face when there is a COVID crisis. And right now we would be, if anybody is seeing a person who is isolated or quarantined, it would be great to hear what you have perceived or you have understood from that person. Hello? Are people thinking, or does anybody want to share some experience? I would like to ask a few of you to share your own experience now that we are facing with this very uncertain situation. Uh, we are also under, many of us are under lockdown, many of us have gone through, some of them I have been quarantined, I guess. Um, some of some of us are not away from our families, not living alone. Can some of you just face the challenges that you face in terms of your emotional status? Can one of you start it off? Moira?
Yes, thank you, Chitra, and thank you for the session. I mean, I think everybody is what's striking me is how fearful people are and how anxious. And although we have these mechanisms for communication, they don't replace that easy, comfortable face-to-face. So I think what I'm hearing from people contacting me and speaking to me is really quite high levels of anxiety, a little bit, not paranoia, but, you know, a single symptom will have somebody awake all night, not able to cope. And this sense in which people are not able to cope together in the way they normally would, and how isolating that is.
Yeah. So the participants from Sri Lanka, how is it in your country? What is the general feel like? I mean, globally we know what's happening, but I know that many of you are from Sri Lanka this time. Can you just give me some experience about what's happening there? Have you met any people who have expressed any kind of distress to you? Pankaj from AIMS? Pankaj?
Hi, madam.
Pankaj, I know that you have you seen any persons with COVID, or have you been, taking duties or seeing people in isolation ward or anything? I know that AIMS is seeing patients with COVID infection.
No, sorry, madam. I am working in KMC Manipal, right?
Oh yeah, I know. Yeah. I'm
So,
sorry, Pankaj.
yeah.
So what
we
about
haven't
Manipal? Does
seen
it
any
have any?
patients. We haven't seen any patients or like any patient in the quarantine. But yeah, a lot of calls comes from our friends and all who
So
are at home.
what kind of
Yeah.
issues do they discuss with you?
Yeah, so the main worry they have they are either alone at home, and most of the time they are worried that when they will come out of it, or they are worried what will happen, whether they will catch the infection. So a lot of anxiety issues are there.
Okay. Mm-hmm.
Anybody else has any more experience?
I would like to share. Because no one's saying. I want to share something which I'm seeing. Being in palliative care, I'm now going to the palliative care wards, and I've been witnessing deaths in cancer patients, and I see how it is affecting even the COVID situation itself. It is actually magnifying, or amplifying the whole picture. It's not only for the patient or the family itself, it's from our side also. There's a kind of helplessness where you feel that because of the limited settings in terms of communication, or in terms of resources that you have, you feel that you're not really able to really do as much as you could in regular circumstances. So I've been witnessing continuously, I've been witnessing deaths, and people, and we had to send off one person, and then she came back to die. So when she went back home, and there were a lot of calls from the daughter of that patient. So this is actually, I'm getting affected by that. And I also want to talk about one of my colleagues who lost someone, and the way a person who actually is present in her own patient's end of life scenarios was not able to be present in her own family members' end of life state. And that actually is such a dilemma that you are not able to really offer what you want to do for your own family. And that was extremely difficult grief to watch.
Yeah. Thank you, madam. So we had one patient who was admitted with advanced malignancy.
Mm-hmm.
And both of these patients were from Tamil Nadu, and because of lockdown, nobody from Tamil Nadu were able to come and see the patients. When the patient was end of life, we actually discussed with the patient and the husband for getting them back to Tamil Nadu, but they were not willing. But on the day of death, they suddenly wanted to go, but the situation was not in favor of transferring because she was gasping. And she had two children, but she was unable to see them, even though we were looking forward to bring them both to patients to Trivandrum, but it was not possible to bring them to Trivandrum. So they were able to see the kids through the WhatsApp call, video conferencing.
Yeah.
So that was something which our staff also echoed. and they told that was distressing to see that the patient couldn't see both of the children. So that was one experience that happened during this time.
Yeah, I think it is quite for us, uh, though we are, I mean, in palliative care. I mean, I know that many of us are not in palliative care in the audience. We are quite used to morbidity and mortality as well. But I think this unusual circumstances actually making us also slightly more nervous and more cautious, more wary about what uh, we can offer and how we can offer to our utmost capacity. Are we really doing it well to the extent that we can really do?
I think, if I just come in, I think that's a very good point, and I think we need to just hold those. We need to not expect too much of ourselves,
Yeah.
and be a little kind to ourselves and each other. But also, Sunil, you brought up a nice point. My neighbor, her mother died. She's in Uganda. Her mother died in the UK, and she's got siblings in 2 other continents. And they're going to have they had a WhatsApp call before she died, but they're also going to have a WhatsApp funeral today. And they've all agreed to do some rituals in the different places and then join in together. She's asked all of us as neighbors to light a candle. So there may be ways in which we just have to support things happening in very different ways, but still help people to find ways to express how they're feeling despite the isolation.
Yes.
Any more comments? Okay. I don't see anybody is coming up with any comments or questions.
Yeah.
So I think we can wind up this session. So thank you, Dr. Seema, for your wonderful session, and thank you all for this interactive session. We'll see you tomorrow with end of life care and grief and bereavement.
Thanks so much.
Thank you.
Thank you.
Okay, thank you, Seema ma'am. And we have a poll. You can see in your share. You already shared this poll. And please put your valuable feedback. Before leaving the meeting, please take feedback and leave. It's a request.